Assalamu alaikum wa rahmatullahi wa barakatuhu. Welcome back to the channel of Stand Medical Notes. Today let us discuss about today let us move forwards and discuss first about the how to approach the case of acute heart failure. Then we will discuss in detail about the treatment of acute heart failure, and in short about the long term treatment of heart failure. So whenever a patient approaches in the emergency department with suspected heart failure, this is a very good algorithm which is given in Oxford textbook. Suspected acute heart failure. So first of all, you rule out shock in that patient. So decreased BP is any patient which we are evaluating, we are first evaluating the most worst thing in that patient. No, so that's how the bad thing in this heart failure is shock. So first we are seeing whether there is cardiogenic shock. If it is there, then we will provide some circulatory support, either mechanical or pharmacological or mechanical. Now, if it is not there, then we will see whether there is respiratory failure, so whether the saturation is less than, suppose, 95 or less than 90. Okay. If yes, then we should give ventilatory support depending upon the severity of decreased severity of respiratory failure. It can be in the form of oxygen normal, or it can be in the form of CPAP or BiPAP or mechanical ventilation in severe cases when the patient doesn't have consciousness. Okay. So if we now, after seeing this, we will immediately stabilize the patient and transfer the patient to the ICU, intensive care unit. Now that was the first medical contact. Now in the ICU, in the immediate phase, that means in 1 to 2 hours, so along with giving support, we also we also evaluate the etiology of the heart failure. Etiology, what's causing the heart failure, we evaluate that thing. Okay. So there is very good mnemonic to evaluate heart failure. What is that mnemonic? Remember this CHAMP. Apart from giving support, or you can also call the immediate life-saving support, we evaluate the etiology. How? CHAMP: C for coronary syndrome, H for hypertension emergency, A for arrhythmia, M for mechanical cause like some ventricular hypertrophy or some valvular disease. Okay. P for pulmonary embolism. So CHAMP is an easy mnemonic to remember to evaluate for the cause of acute heart failure. Okay. So C for coronary syndrome, H for hypertension emergency, A for arrhythmia, M for mechanical cause, P for pulmonary embolism. Now, if any cause is found, immediately you initiate specific treatment for that. Okay. If no cause is found, then diagnostic workup to confirm acute heart failure and clinical evaluation to select optimal management. Okay. So this is the easy approach we should follow whenever we suspect a patient coming with acute heart failure. Okay. So this is the treatment algorithm recommended by the European Society of Cardiology, ESC. The investigations and active management, this is important. Sorry. The investigations and active management have to be undertaken simultaneously. Okay. Now this is another chart from HARRISSON textbook. So first you will take history and examine the patient, then you will suspect some acute heart failure. You will do ECG, chest X-ray and laboratories. Laboratory test. What is that laboratory test? We will order for CBC, CRP, okay, LFT, RFT, electrolytes, thyroid test, troponin levels, and NT-proBNP. These are the basic lab tests which you order. Okay. Then you will do echocardiogram and you will classify the patient as HFrEF, HFrEF, HFbF, HFpF. Depending upon this classification, the further treatment will depend upon. Okay. Then we will determine the cause. Okay. How do you determine the cause? By CMR, cardiac magnetic resonance, CT, angiography or PET. So by that you will know any ischemia or ischemia is present or not. Okay. And other than that, this is radiological investigation to know the cause. CMR, CT, PET. Then this is important, coronary angiography you will do, angina or ischemia, chest pain or risk factors for that, and screening for this hemochromatosis, amyloidosis you will do. So one side you will determine the cause, another side you will stratify the risk. This is important. Why? How you will stratify the risk? By NYHA classification. Okay, and this NT-proBNP, this will help in knowing the prognosis of the patient and also help in risk stratification also. Hemodynamics, family history of any sudden cardiac death, cardiopulmonary exercise test, ambulatory rhythm monitor. All these are the things which one doctor does to know to stratify the patient and to know the prognosis of the patient and whether there is improvement or no improvement. For that we use all this. Easiest among this is this NHI classification and this NT-proBNP level. Okay, hemodynamics also we can do. Okay, this is about risk stratification. So this is somewhat there. So here the explanation is there. The initial evaluation starts with a thorough history and physical examination, focusing on detection of comorbidities including hypertension, diabetes, and dyslipidemia. So first we will detect comorbidities. In addition, identification of valvular heart disease, vascular disease, history of mediastinal radiation or exposure to cardiotoxins, example chemotherapy, so alcohol or illicit drugs may help determine the underlying cause. A family history of sudden death, heart failure, arrhythmias, and cardiomyopathy is also useful. Routine laboratory evaluation should also be performed. Chest X-ray is useful to detect cardiomegaly and fluid overload and to rule out pulmonary disease. A 12-lead ECG should be performed to detect abnormalities of cardiac rhythm and conduction, left ventricular hypertrophy, and evidence of myocardial ischemia or infarction. Two-dimensional echocardiography with Doppler imaging is indicated to assess cardiovascular structure and function and detect abnormalities of the myocardium, heart valves, or pericardium. Further imaging and laboratory studies aimed at identifying a specific cause of cardiomyopathy depend upon information obtained from the history and physical examination. In all patients, risk stratification should be performed to assess severity of illness, then guide therapy and provide prognosis to patient and family. CMR, meaning cardiac magnetic resonance imaging, CT, these are all what short forms. So these tests depend upon the initial investigations and history and physical examination which we do. Okay, depending on the cause. So we'll do CMR, CT, or PET, and coronary angiography. And this is very rarely done. Screening for hemochromatosis, amyloidosis, and sarcoidosis, and also this endomyocardial biopsy. Okay. So these are additional tests. Remember, second line test you can say. Second line test. These are second line test. Okay. And this is risk stratification. So let's move forwards. Now we will talk about the management of acute heart failure. Okay. We'll talk about the management of. So in management of acute heart failure, what is the goal? What is the goal? Sorry. So the goal is to stabilize the hemodynamics, BP, okay, heart rate. You should stabilize, relieve the congestion, and treat the precipitating cause. Very important. One, to stabilize the hemodynamics, saturation, BP, heart rate. Okay. Second, to relieve the congestion. Okay. Third, to treat the precipitating cause. So stabilize the hemodynamics, relieve the congestion, and identify the cause. Okay. So initial assessment and classification. So this is very easy. So I will take this one upside, scroll it up. See, this is a very important diagram for managing a case of acute heart failure. So you can classify it as, for management purpose, cold and wet, meaning cold is nothing but hypoperfused, wet is nothing but congested. Okay. Warm and wet, warm is nothing but perfused, wet is nothing but congested, congested but perfused. Warm and dry, nothing but compensated heart failure. Dry, there is no congestion. Warm, there is no shock also. Okay, that is compensated heart failure. Cold and dry, that means hypoperfused only, there is no congestion. Okay. So this cold and wet, I said no, heart failure with hypotension is the baddest thing, which is worst thing, which we'll see in patient of heart failure, except in some cases like right ventricular infarction and inferior MI, which is associated with heart failure. So other than that, HF with hypotension is a bad thing. So this is most critical. So this will need inotropes and careful diuresis. So you need to balance, because diuresis causes to decrease BP further, and inotropes, okay, inotropes and diuresis. And this is the most common phenotype which you see in patients with acute heart failure: warm and wet, congested perfuse. So you will use diuresis and nitrates, vasodilators, nothing but nitrates. Okay, warm and dry is compensated. OPD you will manage. Okay, cold and dry you will give again. What do you call? Inotropes. Okay, here is a very important diagram. So warm and dry, outpatient treatment. Okay, warm and wet, warm and wet. Okay, you give diuresis and nitrates. Okay, cold and dry you will give inotropes. Cold and wet you will give diuresis, inotropes, and vasodilators. Okay, in this, these two are important: diuresis and inotropes. Cold and wet. Cold and wet. That is nothing but, this is the worst. This is the most critical one. Most critical, and this is the most common. This is the most common. Most commonly, you will see this type of heart failure. So this diagram, you are just knowing. Now you have to know that you are going to give diuretics for symptomatic treatment and nitrates. Okay, and vasoconstrictors, nothing but inotropes. These are the cornerstone of management of acute heart failure. And guideline directed medical therapy is something which is called, you should give the patient. Okay, that we'll learn in coming slides. So pharmacotherapy, diuretics, how you will give the diuretics now in detail we will learn. So diuretics, IV loop diuretics you will give. For example, furosemide, or also you can give torsemide. Okay, this is first line for congestion. So in that, you should monitor urine output and electrolytes. So whenever there is volume overload, nothing but congestion, pulmonary congestion or systemic congestion. So either it can be moderate. I will just zoom it out. So if it is moderate, give furosemide 20 to 40 mg per day per oral or IV. If it is severe, give IV 40 to 100 mg IV, or as continuous infusion you can give 5 to 40 mg per hour. 5 to 40 mg per hour as continuous infusion you can give. Continuous infusion may be more effective than very high IV doses. Okay, the collective dose usually does not exceed 100 mg over the first 6 hours or 240 mg over the first 24 hours. The collective dose should not exceed 100 mg over the first 6 hours and 240 mg over the first 24 hours. Okay, continuous infusion. Okay, in continuous infusion, 100 mg over the first 6 hours and 240 mg over the first 24 hours. Okay, so either you can do bolus or infusion. Similarly, torsemide, half the dose. Torsemide dose is half the dose of furosemide. Okay, 10 to 20 mg per day or 20 to 100 mg per hour. Now, still after giving this, you are having the congestion. So you can either add thiazide diuretics or mineralocorticosteroid antagonists like spironolactone. 50 to 100 mg of hydrochlorothiazide and 25 to 50 mg of spironolactone. Adding a thiazide diuretic or spironolactone is preferred over using very high doses of loop diuretics. Okay, and spironolactone is preferred in patients without renal failure and with normal or low serum potassium levels. Spironolactone. Okay. Again, the patient is not responding even after giving addition of thiazide diuretics or spironolactone, aldosterone antagonist. So what you will consider dobutamine. So you are increasing the contractility of the heart, or dopamine, or hemodialysis in patients with concomitant renal failure or no response to treatment, or ultrafiltration, ECMO. You can consider ECMO. Okay, extracorporeal membranous oxygenation. Okay. When there is volume overload, you will perform hemodialysis, okay, or ultrafiltration. Hemodialysis or ultrafiltration is the next step. So, first of all, furosemide or torsemide Second, addition of thiazide diuretic and or spironolactone. Third, ultrafiltration. Again these drugs, dopamine, ultrafiltration, and hemodialysis. So that's how you give the patient with diuretics. That is the procedure. Okay. This is from McMaster textbook of medicine. Now we will now see how you will monitor the patient. Okay. That's the dosage we have learned depending upon the severity of the congestion. I will just zoom it out. See here. Treat underlying cause of acute decompensation. Treat underlying cause of acute decompensation. So along with giving this symptomatic therapy, you should treat underlying cause of acute decompensation. Consider invasive care when appropriate. For example, in acute coronary syndrome, mechanical complications of a myocardial infarction. What is that mechanical rupture of chordae tendineae or rupture of septa of the heart, okay, or rupture of ventricles, or endocarditis, valve disease. So whenever invasive care is appropriate, consider that thing. So when a patient comes with acute pulmonary edema and he has congestion, so one, you should give IV loop diuretic. Okay, what is the dose? At a dose 2.5 times higher than in long-term treatment. Okay, repeat when necessary. And if the saturation is less than 90%, use oxygen therapy. High concentration oxygen. Start with fraction of inspired FiO2 40 to 60%. That means 0.4 to 0.6, and target the SaO2. So oxygen saturation to more than 90%. If there is no response, consider non-invasive ventilation or intubation and mechanical ventilation. Okay, 0.4 to 0.6 you should keep. In case of severe anxiety or agitation, consider IV opiates, for example morphine. And if morphine is not available, you can give tramadol. Okay, tramadol 100 mg as infusion. Okay, so remember 1 mg of morphine is approximately equal to 20 mg of tramadol. This is according to this 1 mg is approximately equal to 10 mg of tramadol according to McMaster textbook of medicine. Okay, so how you will monitor when you are giving diuretics? Measure the BP. If the BP is more than 110 mmHg, initiate and or titrate guideline directed medical therapies. What are the guideline directed medical therapies? Remember 4 drugs. These 4 drugs comprise guideline directed medical therapy. Number 1, ACE inhibitors, ARBs, or ARNIs, angiotensin receptor neprilysin inhibitor. Number 2, beta blockers, cardioselective beta blockers, vasodilating particularly. Okay. Number 3, SGLT2 inhibitors. Okay. And number 4 is mineralocorticoid antagonist. The example, spironolactone. So these 4 consider guideline directed medical therapy. So if the patient is stable and the BP is more than 110 mmHg, consider initiate this guideline directed, because these are the drugs which we have learned in the pathophysiology, that there is a circuit which will fail the heart progressively. Gradually the heart will lose its function, lose its contractility. So that circuit will be broken by this guideline. GDMT it is called, GDMT, guideline directed medical therapy. Okay, so that you should start. Now, if the BP is 85 to 110 mmHg, continue the current therapy. If the BP is less than 85 mmHg, then you should add a inotropic agent with no vasodilating effect. Now, after all these things, if there is response to therapy, then continue the current therapy. If there is no response to therapy, so depending upon the BP, you are deciding what to do next. If the BP is more than 110, you are initiating GDMT. If the BP is 85 to 110, then you are continuing the current therapy. And if the BP is less than 85 mmHg, you are starting an inotropic agent. Now, if the patient is having a good response, you are continuing that. If the patient is not having response, then consider assessment of treatable causes of cardiogenic shock. Increase the dose of inotropic agent, add a vasodilator, hemodynamic monitoring, and circulatory support. So this is a very important charts which I am discussing from different standard textbooks. Okay, so that's one thing which diuretics which you will give in patients. Okay, now coming to vasodilators, and among them the most important is are nitrates. So vasodilators, IV nitroglycerin and or nitroprusside. These are considered patient with warm and wet. Means congestion is also there, but BP is maintained. Adequate BP. Adequate BP. There you consider this vasodilators. They reduce preload and afterload. But caution. You should caution. They should be avoided in hypotension. And in acute coronary syndrome, nitroprusside should be avoided. Nitrates you can give. And in significant valvular stenosis also, you should avoid vasodilators. Okay. So in hypotension and in significant valvular stenosis. In hypotension and in significant valvular stenosis, you should avoid vasodilators. Okay. So this is a table of management of acute pulmonary edema. What is the type of pulmonary edema? Wet and warm. Wet and warm. For that, you should manage like this. Make the patient to sit up in the 45 degrees angle, no? 45 degrees angle. That reduces the preload. Okay, that reduces the preload because it will decrease the venous return. Okay, and the patient will have less breathlessness. And give high flow oxygen. That will correct hypoxemia. If that high flow oxygen is not working, ensure CPAP of 5 to 10 mmHg by tight fitting mask. It reduces preload and pulmonary capillary hydraulic gradient also. So now patient is sitting up, you are giving oxygen, patient is stabilized. Now you give nitrates, either IV or buccal, okay, or sublingual also if you don't have buccal. IV glycerol trinitrate, the dose is 10 to 200 microgram per minute. 10 to 200 microgram per minute. Okay. The dose of nitrate should be titrated upwards every 10 minutes until there is an improvement of systolic BP is less than 20 mmHg. Okay. So what that means, this as BP systolic blood pressure of point of 110 is very critical for monitoring the patient. In diuretics also we have seen, and in nitrates also we are seeing here. Okay. 110. More than 110 is very safe. Okay. And then administer a loop diuretic like furosemide 50 to 100 mg IV. So either you can give in bolus dose or as infusion also you can give. That combats fluid overload. Okay. So that's a very crisp management and very crisp and very good management of acute pulmonary edema, wet and warm. Okay. Now we'll move forwards for other things which we give for patients with. So inotropes are required when the patient is dry and wet and dry, or wet and dry, congested. When the patient is having hypotension, you need to do inotropes. So preferred inotropes are dobutamine and dopamine, remember, and norepinephrine. These three are the preferred. This is vasopressor actually, but the preferred one are dobutamine and dopamine, and in vasopressors is norepinephrine. Actually, we will see that one. So this inotropes are for cold and wet, means the patient is having pulmonary edema or systemic congestion, but along with that he is having hypoperfusion. So but what is the thing which is bad thing which is going to happen? Okay, there is increased myocardial oxygen demand and there is a risk of arrhythmia. So you should use it short term only. Okay, norepinephrine for cardiogenic shock with profound hypotension. The hypotension is very much. Okay, so you will give that. So what is the use of opioids? Use sparingly only for severe anxiety and pain. Why? Because this anxiety and pain will increase the tachycardia. They will activate the sympathetic nervous system, which is going to damage again. So if you calm the patient, so that sympathetic activation is reduced, no? So that's why you give opioids. So this is a table which describes the dose of inotropes. Dopamine, remember, in less than 3, if the dose is less than 3 microgram, it acts as a vasodilator. More than 5 microgram, it acts as a vasoconstrictor. Between these two, meaning between 3 to 5 microgram per kg per minute, this is the cardioprotective dose. So you should give, if you get dopamine, you should use the dopamine in these doses, 3 to 5 microgram. Used in patient with AHF with low BP. Low dose dopamine is often used in combination with higher doses of dobutamine. Survival on dopamine may be worse compared with norepinephrine in case of cardiogenic shock, hypotension and hypoperfusion. Dovitamin, the dose is 2 to 20 microgram per kg per minute. Again, this is also having the same. Low dose will cause vasodilation, high dose will cause vasoconstriction, and intermediate dose will have cardioprotective effect, increase the myocardial contractility. So used to increase cardiac output, it stimulates the beta 1 receptors, increases myocardial contractility, increases heart rate. Lower doses causes vasodilation while higher doses cause vasoconstriction. This is important. Infusion over more than 24 to 48 hours is associated with the development of tolerance and partial loss of hemodynamic effects. Discontinuation may be difficult because of recurrent low BP, congestion, or kidney failure, which is why the infusion rate should be reduced gradually. Important. Infusion rate should be reduced gradually, not abruptly, by approximately 2 microgram per kg per minute per day, and it should be used together with optimized vasodilator therapy, example oral AC inhibitors. This may cause ventricular and supraventricular arrhythmia and chest pain in patient with ischemic heart disease. So what important points we should take from here? Intermediate dose we should use, okay. More than 48 hours if you use, then it will lose some of its effect on the heart, and you should not abruptly discontinue the infusion. You should reduce the infusion gradually by 2 microgram per kg per minute per day. That is one thing, and you should keep in mind inotropes can precipitate arrhythmias. Milrinone leaf. So the next important drug is NorEpinephrine, which you use. The dose is 0.222 microgram per kg per minute. Use with caution only in patients with cardiogenic shock and the BP is less than 90 mmHg when organ perfusion is inadequate. In spite of other interventions, you are given dopamine, but still the patient is in hypotension, the BP is less than 90, then you can give NorEpinephrine. May be indicated in shock patients with acute heart failure and sepsis. May be combined with each of the above inotropic agents. Use with caution in combination with dopamine. So you can combine without any fear with dovitamin, but with caution with dopamine. Okay, dovitamin you can combine. Next thing, which is epinephrine, is mainly used in when there is cardiac arrest. Okay, during CPR you use. Digoxin is the next important thing which we use. Loading doses 0.5 to 1 milligram followed by 0.125 to 0.375 milligram per day, and monitor serum drug levels. This is effective in patients with acute heart failure caused by tachyarrhythmias, atrial fibrillation. Not recommended in patients with acute heart failure after acute MI because of its pro-arrhythmic effects. Okay. So AHF with AF. Digoxin is the drug of choice. Provided MI should not be there. Because of its position, not be there. Okay. Loading dose is 0.5 to 1 mg and followed by 0.125 to 0.375 mg. Monitor the serum drug levels. That's about the inotropes, which increase the nothing but which increase the contractility of the heart. Vasopressors, which increase the BP. Okay, and then digoxin. We will move forwards. So this is the supportive care which you will give in a patient with myocardial infarction. So if oxygen saturation is less than 90%, you give oxygen. Okay, ventilatory support if by, for example, HFNC, high flow nasal cannula, 0.4 to 0.6, still there is less than 90%, you can consider non-invasive CPAP by pipe, and if the patient is not responding to this also, you can give mechanical ventilation if refractory hypoxia or respiratory fatigue. And again, if the patient is not responding to this also, you can give mechanical circulatory support, nothing but ECMO, extracorporeal membranous oxygen, as a bridge to decision recovery or transplant for refractory cardiogenic shock. Okay. So this is management post acute heart failure. Now, I have said in one video that whenever a particular part of the body, for example, kidney or lung, ceases to function, they will cease either abruptly, that is acute, or gradually, that is chronic. Chronic is irreversible and acute is reversible. But remember one thing, that when there is acute thing which is happening to one organ, so still it will leave some residual either circuit like thing which will progress and slowly make the organ to die, okay, or it will have some damage if you delay the intervention. It will do some damage, but that organ will recover. But it will have some damage. So that is acute. Okay, chronic, whatever you do, you can retard the progression, but yeah, that failure is going to happen. So to retard the progression and to break the circuit in acute heart failure, after heart failure, we need to use some drugs that is known as GDMT, guideline directed medical therapy, and that is different in cases. It is different in HFrEF, HFbEF, and HFpEF. Is that right? Okay. In HFrEF, four drugs you should use. In borderline and also in preserved, in these two, only two things are necessary. This one, and three things. Three things are necessary in these two. In HFrEF, one more thing is MRA. Okay, MRA. Okay. Foundation principles of therapy in HFrEF. Echo you will do, and according to echo you will see the phenotype. So if it is HFrEF, you will give ACE inhibitor or ARB or ARNI. ARNI is nothing but angiotensin receptor replacement inhibitor. Okay. Start with ACE inhibitor or ARB, switch to ARNI, sacubitril valsartan combination if still symptomatic for superior outcomes. Beta blocker. So preferred in beta blocker is vasodilatory beta blocker. So that is carvedilol or nebivolol. Okay. Bisoprolol you can use, metoprolol you can use. Start low, up titrate to maximum tolerated dose. Okay. So BP you should maintain. If the BP is between 95 to 110, then okay. And heart rate should be targeted to 55 to 60 beats per minute. This is the target heart rate. Okay. Then mineralocorticoid receptor antagonists like spironolactone, eplerenone. Okay. Monitor potassium and creatinine, and SGLT2 inhibitors like dapagliflozin or empagliflozin. Empagliflozin is more preferred than dapagliflozin. Benefits in all types of heart failure, whether it is REF or MREF or PEF. Okay. So this will reduce the mortality, hospitalization, and improve the symptoms and quality of life. Remember these four drugs. Okay. In detail, we'll talk about these drugs in chronic heart failure. Just to remember here. Additional therapies, what you should consider. Diuretics you will give for symptom control of congestion. Use the lowest effective dose. When you will consider Ivabradine, when the patient is in sinus rhythm and the heart rate is not targeted, means it is going more than 70 beats per minute, then you can combine this Ivabradine. And remember, Ivabradine acts directly on SA node. So if the rhythm is not a sinus, then Ivabradine will not be effective. Okay. So only when there is sinus rhythm, you can use Ivabradine. When the beta blockers are contraindicated, or even after giving beta blocker, the heart rate is still more. Okay. Hydralazine plus isosorbide dinitrate for African American patients with HFrEF on standard therapy or intolerant to ACE inhibitor, ARB, ARNI. Digoxin for symptomatic relief in HFrEF with sinus rhythm, especially with AF. This is important. With AF, okay, when there is atrial fibrillation, digoxin you can give. So now nowadays this digoxin, this is the last chance which the physicians will choose. They are not choosing the digoxin. Okay. IV iron you should use like for FCM, ferric carboxymaltose, for patients with iron deficiency. What does it mean by iron deficiency in patients with heart failure? Ferritin levels are less than 100 or in between 100 to 300. With TSAT, nothing but transferrin saturation are less than 20%. So when the ferritin level is less than 100 and TSAT is less than 20%, then you should give the iron to maintain the ferritin level more than 100 and TSAT more than 20%, 20 to 40%. This is 100 to 300. You should maintain this one. You should check ferritin and TSAT levels. Okay. Anticoagulation, when there is concomitant AF, okay, you should plan for anticoagulation. So iron therapy, anticoagulation. Okay. Device therapy. So when you will plan for device therapy, ICD, intracardioverter defibrillator, for primary or secondary prevention of sudden cardiac death. Cardiac resynchronization therapy. for symptomatic HFrEF with left bundle branch block and QRS duration is more than 150. These are the indication for CRT. Remember, cardiac resynchronization therapy. What are the indications? The patient should be symptomatic with HFrEF with left bundle branch block with QRS duration more than 154 conditions for CRT in patients with heart failure. More conditions. What are those conditions? Patient should be symptomatic. Patient should be symptomatic, number 1. Number 2, patient should be in HFrEF. Number 3, symptomatic HFrEF with left bundle branch block and QRS complex should be more than 150 milliseconds. Nothing but more than 4.5 small squares. So when these 4 conditions are met, you can try CRT. So what is the non-pharmacological management? Salt and food restriction, daily weight monitoring, cardiac rehabilitation and exercise, multidisciplinary HF clinic management, failure to care consultation for advanced stage D heart failure. That's about the non-pharmacological management of heart failure. That's also very important. Okay, very important. Prognosis and special considerations. Prognosis remains poor, especially post-hospitalization for acute heart failure. In-hospital mortality for acute heart failure is 10 to 15%, rising to approximately 60% at 30 days in cardiogenic shock. Cardiogenic shock is a very bad thing. Heart failure patient coming with less BP is not a good thing. It is most critical. Okay. The second thing is cardiac cachexia. What is cardiac cachexia? It is also a poor prognostic sign. How do you define that? Unintentional, non-edematous weight loss. Unintentional, non-edematous. Edema is there, but still there is weight loss. More than 5% in 12 months. Unintentional, I'll write here. Unintentional, non-edematous, weight loss of more than 5% in 12 months, in 1 year. So what is this? This is a poor prognostic sign. Poor prognostic sign. Okay. That is cardiac cachexia. Comorbidities, diabetes, CKD, sleep apnea, depression, iron deficiency. Remember this, these are very important comorbidities of acute heart failure patients. Okay, they will have diabetes, they will have CKD, they will be obese, sleep apnea will be there, they will have depression, they will have iron deficiency. Significantly impact outcomes and must be managed aggressively. So remember the 5 comorbidities: diabetes, CKD, depression, iron, sleep apnea. Diabetes, CKD, sleep apnea, depression, iron. 5 comorbidities you should manage aggressively. Okay. Transition care. Post discharge, follow up the patient within 7 to 14 days is critical to optimize medications. So you will increase the dose of AC inhibitors and beta blockers and diuretics. Okay, according to the patient BP, heart rate, edema, all these things you will optimize by calling the patient every 15 days. Okay, so that's all about acute heart failure. In the next topic, in the next video, we'll talk about chronic heart failure. Thank you for your listening. Do share if you like this.